ना फर्स्ट बीच में से आया, नहीं डाउन करना पड़ेगा। So I'll be starting my talk on mallet fingers. Am I audible to all of you?
Yes, sir.
Okay.
Yes, sir, you're audible.
Mallet finger injuries are very common in I'll start my talk. Mallet finger injuries are common injuries that we encounter in our day-to-day practice. By definition, it is avulsion of the DIP extensor tendon of the finger. It is also called baseball finger or drop finger. The tendon may be stretched, completely torn, or may be associated with a small bony fracture, avulsion, or a bigger piece. The mechanism of injury of a mallet finger is sudden flexion of an extended finger, which many times occurs in sports in baseball players and in ladies when they are making up the bed for the mattresses. It is common mostly in the young and the middle-aged, predominantly males around 34 years and in females in the 4th decade. 70% of the hands is the dominant hand. And in 90% of the cases, the ulnar 3 digits are involved. Within the first 4 weeks, it is called acute. Subsequently, from 4 to 6 weeks, it is chronic. It is classified by Weber's and Sinder's classification, with grade 1 has no subluxation, grade 2 has with DIP joint subluxation, and 3 has epiphyseal and transepiphyseal injuries. And again, subdivided into A, B, and C. A better classification is Doyle's classification. Grade 1 is close injury with or without avulsion. Grade 2 is open injury. Grade 3 is open injury with skin loss with or without part of the extensor tendon. And grade 4 is growth plate fractures in pediatrics. B is 20 to 50% involvement of the articular cartilage, and C is more than 50% of the articular cartilage. Treatment in most of the cases is by splinting for 6 weeks. Commonly, we use an aluminum dorsal splint, but the most important factor for a conservative treatment is very good patient compliance, and at least for 6 weeks. And if in between it is lost, then you have to start splinting again. A variety of splints are used: aluminum splints, plastic splints, fiber coated splints, which have to be given for 6 weeks. After 6 weeks, you can have a night splint, and in the daytime, you can ask the patient to move the fingers. But if the extensor lag is persistent, you have to continue splinting. And beyond 6 weeks, you may consider surgery. These are a variety of splints which are available in the market. I will not go into the details of all the splints. You can use one which gives better aeration to the fingers and does not make the skin soggy. Because the main problem with splinting is sogging of the skin followed by ulceration. And if the splinting is not proper, you get a swan neck deformity. If your conservative treatment fails, then you go for surgery. So a failure of conservative treatment is an indication for surgery. If more than 25% of the joint is involved, or if there is subluxation, or if it is a compound injury, you can go in for surgery immediately. Surgery consists of fixation with K-wires, screws, which I'll be talking about subsequently. Previously, we used to give plaster with the DIP joint extended and PAP joint in flexion. And this was continued for 6 weeks. Whenever it gets loose, you reapply it again. Katzman had made a detailed analysis of this, and he says that only DIP joint immobilization is required, and you do not have to fix the PIP joint. A simpler method would be a fixation of the fracture with a K-wire followed by the splint, which will give better results. A K-wire and a plaster. For a displaced fracture, which is not amenable to good reduction in conservative, the gold standard is 1.1 mm AO screw. You do an open reduction and fix it with a screw, which gives very good results in selected cases. This is the follow-up of a screw fixation at 3 months. When these screws are not available, I prefer using stainless steel wire pull-out sutures. Do a open reduction, and with stainless steel wires, using a button, fix the fragment. These are some of the cases and the end result of stainless steel wire pull-out sutures. One of the commonest method of doing this is DIP joint transfixation. A closed method. You pull the bony piece, flex the finger, the distal phalange, extend it, and put in a transarticular K-wire. If there are 2 pieces, you may use 2 K-wires for DIP joint transfixation. If with the DIP joint transfixation, you are still not able to bring the piece together, a hook of the K-wire is made, and you pull the wire as a hook to bring that piece into place and transfix the DIP joint, as shown in this case. The most common faults that we find with this surgery is a loss of extension, which is very common. In almost 40% of the cases, you will find 3 to 6 degrees of loss of full extension of the DIP joint. Another method is a pull-out K-wire, where you can see 2 pieces of the distal of the mallet finger. 2 K-wires have been used to pull the piece into place. And the refinement of this technique is the delta wire technique, wherein you push the wire, bring the piece in place, put another wire horizontal to the distal phalange, and tension them together. The idea over here is to keep the DIP joint free and allow mobility of the fingers. This was described by Bipin Kumar and Garg, and it's a good method. The problem is if you are not able to hold the piece properly, there will be resultant non-union. Another method is same transfixation, but the wire passing out on the volar surface. Just showing that if you do not have a good reduction, you will have a malunion of the fracture. Another method is applying a hook plate. These are not freely available in our market, and this case is just being shown to complete the list of surgeries that can be performed. A small hook plate applied at 3 weeks to fix the piece. The piece has to be big enough, at least 25% to 30% of the articular surface. Another method, is a modified technique of Zhang and Wang, wherein you suture back the mallet extensor tendon slip, as shown in this case. Due to lack of time, I will not go into the details of this. Now coming to chronic mallet. Injuries more than 4 weeks old are termed chronic mallet. I would term them as chronic mallet beyond 6 weeks. Various methods have been described for chronic mallet, like central slip release, lateral band mobilization, Thompson's procedure, oblique retinacular ligament reconstruction. This is a primary suturing as described by Wang. Another similar method is excision of the scar and doing a suturing back of the skin and the tendon has a single unit, which gives fairly good results in a chronic mallet. And in late cases, you can go in for a palmaris longus graft as described by Zhang Li and Kai in this case. When you have an old persistent chronic mallet finger with a swan neck deformity, a Thompson's procedure is as described over here in this diagram. Now coming to the jersey finger. The jersey finger is the reverse of the mallet finger. It is an avulsion of the FDP from the base of the distal phalange, with or without a bony piece. The patient is not able to actively flex the DIP joint, unable to fully flex the PIP joint. There may be tenderness along the sheath of the finger. And if the tenderness retracted into the palm, you might find tenderness in the palm. This is how a jersey finger looks like. On maximum flexion, you are unable to flex the finger. The mechanism of injury commonly occurs in football players and rugby players when they grab the jersey of an opponent. The flexed finger is forcefully hyperextended and the tendon gives way. So as I told you previously, you palpate along the finger, there will be tenderness, a bony piece if present will be palpable, and the patient is unable to flex the DIP joint when the PIP joint is held in extension. The treatment is usually surgical and the diagnosis has to be early, and you have to fix it early because late cases will require tendon grafting procedures. Zone 1 injuries for jersey finger. You have a bony piece over there. Or it may have retracted into the palm completely in late cases. These injuries are classified by Leddy as type 1 when it is in the palm, type 2 when retraction is up to the PIP joint level, type 3 is a bony avulsion with tendon attached, and type 4 is tendon is not attached to the bony fragment. It is mandatory that you repair these injuries within 7 to 10 days. The types of repair could be a direct repair or tendon advancement. Direct repair is feasible if you have more than 1 centimeter of the FDP incision. And in most of the cases, you will have to do tendon advancement. The diametric representation of how you do a reattachment of the piece to the distal base of the distal phalange using a pull-out suture. A study of whether an anchor is better or a pull-out suture is better had been performed, and it was found that buttons and pull-out sutures are much stronger than an anchor, and it's a cheaper and an easier way of doing a repair of the jersey finger. With 4 strands and 8 strands, the pull-out strand of button was better than an anchor in the study. Tendon advancement was advocated because it was felt that repair within the seat would decrease the movement and cause adhesions. But the disadvantage of a tendon advancement is that you are shortening the flexor system. You can create a contracture and you might create a quadrugia effect. What is a quadrugia effect? Can be explained by the reins of 4 horses pulling a chariot. If 2 of the strings are short, the excursion of the tendon of all the fingers will be restricted and you will have a loss of grip strength. 2 cases to be shown. A bony avulsion fixed with a K wire to anchor it, and then a pull-out suture was done. Another case is a variant, a comminuted fracture of the distal phalange, which has a big piece of the FDP attached and pulling it forward, a jersey variant fixed with K wires. Thank you.
Thank you so much, sir. Yes. Thank you so much, sir. First of all, sorry for joining late due to some Wi-Fi issues. Any questions to sir?
What is your mobilization protocol for jersey finger when we attach it through pull-out suture and a button?
I keep the finger for 3 weeks, and at 3 weeks I started gentle range of motion exercises with the button on. The button I only remove at 6 weeks, not before 6 weeks.
And the dorsal slab is for some 3 weeks only.
For 3 weeks. For 3 weeks.
All the fingers are involved in that.
No, I will try to keep the only. Usually, it involves the ring finger in most of the cases. So, a dorsal splint with the and body strapping, if required, of the little and the ring finger, or maybe incorporating the middle finger. But the thumb and the index finger are free.
And when do you remove the button, the button which is applied over the nail?
Not before 6 weeks. 6 to 8 weeks.
And in Mallet finger, whenever you do that fixation Ishiguro, what is your protocol of removal of the wires?
I keep it for 6 weeks. I take I take a X-ray if there is a bony piece, and I will try to assess the union. Maybe I would go up to 8 weeks, but beyond 8 weeks, I do not keep the wire. A maximum of 6 to 8 weeks is the wire transfixing the DIP joint. But at least in some cases, I have removed it 4 weeks. But then I have found that the extensor leg comes back again because I was not able to assess the healing of the bony piece. And on X-ray, it seems that it has healed up. And in young patients who are very enthusiastic of getting the pin removed, I have seen a relapse of that injury at 4 weeks. So I keep it for 6 to 8 weeks. The problem of keeping it beyond 8 weeks is then you again get a finger which is stiff at 8 weeks. So it's walking on the razor's edge between 6 to 8 weeks.
So what is usually said is the block pin, the extension block pin we remove at 4 weeks, and the transfixation pin we remove at 6 weeks. Dr. Samrat, do you have any opinion on this?
No, sir, I would keep it for 6 weeks. The extension block pin also for a longer time, and the transfixation pin for 2 months. Maybe keeping both the things for 2 months. Because for a conservative management of the mallet finger also, we keep the splint for 2 months continuously. That is 8 weeks. And they do very well because the flexors work nicely.
Actually, if you review the literature, 30 to 40% of the cases fixed this way have 6 to 8, 10 degrees of extensor leg and stiffness. And the rating is not always good in terms of range of function achieved. But for practical purposes, the finger is okay.
Right. So, thank you so much, sir. Are we done with Dr. Iyer, Dr. Jitendran Iyer?
No, yeah,
No.
this was the first talk.
First talk, right? Because I joined late. Yeah. Dr. Jitendran, are you ready?
I'm ready.
Yeah. So I invite Dr. Jitendran Iyer. He is a surgeon, a hand surgeon from Bangalore, and we see many replantations and magical surgeries on our group from Dr. Jitendran. So I request him to go through his topic, saving fingers and fingertips, basics of replantation. So what should we do, and what is further to be done? Dr. Jitendran,
Okay.
please.
Okay, I'll just start.
Yes, please.
Yeah. I'll just go. Yeah. Good evening, everybody. So today the topic is saving fingers and fingertips, the basics of replantation. So in this, we'll try to cover what is the basic of replantation. Take. And so replantation is basically when the part is completely cut off from the body and there's no communication between the part and the body. And replantation, it requires good amount of effort every day, and you cannot be complacent. That means that the success is never owned, it is rented, and the rent is due every day, and you have to do everyday work to make it successful. So revascularization is what? When the part is attached to the body, but there is loss of circulation. So where you have to just join the circulation back. You have to bring back the circulation. That's the only thing in revascularization. Okay. So why is replantation important? Is it can restore some amount of function. It can restore the sensation in the amputated part, and it can restore your body image, self-esteem, and it can also help you improve on your career if career limitation is happening because of the amputation. Okay. So what is the basic step in a replantation? The first step is you have to identify what are the vital structures in the amputated part, like the like you have to identify the artery, you have to identify the vein, you have to identify the nerves, the tendons. And the first step is you have to identify all the parts and then do a surgical debridement under a good amount of magnification. There should be a good amount of bone shortening done. There should be a stable fixation, good strong repair of the flexor and the extensor tendons. You do a venous repair first or an arterial repair first, that depends upon you. An artery repair should be done, then a nerve repair and a skin closure. These are the basic steps. Okay. Then how do you start your exploration? You start your exploration by identifying the mid-lateral position. In the mid-lateral position, you give a lateral incision medially and laterally. Around 6 to 10 millimeters of the incision is given. Then you expose the part. First, you expose the dorsum. You try to identify the veins. The veins are just above the extensor tendons, as you must be seeing in their cross finger flaps. The same thing we do exactly, just above the extensor tendon, we identify the veins. And then you dissect them gently and make sure that they are not traumatized. Then you should know the venous anatomy. The venous anatomy, there's some variation in the fingertips. Then the artery. They are located between the Grayson and Cleveland ligaments. and they are just deeper to the nerves in the fingers. The nerve is usually more superficial than the artery. Okay, here you can see the cross section. When you are doing a dissection, you should make sure that when you are coming from the lateral, you just go near the bone and lift the arteries and veins in the volar flap. Then the nerves are, again, they are accompanying the arteries and they are volar to the arteries. So what is the most important part is you should debride it well. You should not just concentrate only on doing the anastomosis. Debridement is a very, very important part, and you should debride it once you have identified all the structures under a microscope. And debridement prevents you from losing your replants later on because of infection. Okay. Then bone shortening. Bone shortening is the most important step, which is often neglected in a replant because we try to preserve as much of length and we end up suturing the arteries in tension. So we should do an adequate amount of bone shortening, and we should make sure that the fixation is good and rigid. If you don't have a good fixation and a good shortening, you'll do an anastomosis in a zone of injury, and or you'll end up in tension during anastomosis, which can cause late thrombosis of your vessels. Then extensor tendons, again, because you can't put any core sutures, you put running sutures. Then venous anatomy, as explained, is just about the extensor tendons. Okay. Then when you are doing a venous anastomosis, sometimes you can just selectively ligate the branches and then get an extended length of the veins. That is one method. And if you divide it, you get double branches. From a single vein, it becomes two veins for anastomosis. Then flexor tendon repair, as far as possible, do a strong tendon repair so that you can mobilize the patient early. Arterial repair, the most important part is we often think that the replant fails because of venous failure. Venous failure also makes a part of a failure, but arterial repair is a more important part where you have failures due to loss of circulation in the part. So you should always trim the adventitia, dilate the vessels, see the lumen clearly, and then you should have a pulsatile flow from the paired artery. If you have pulsatile flow, then you can be sure that you are away from the zone of injury. If you don't have a pulsatile flow, don't do the anastomosis. Go ahead and try to put a vein graft for the artery. Then again, try to do little manipulation, but don't be hard on the vessels, especially the artery and the veins. They can go into spasm, and use the minimal amount of sutures which are required to do a leak-free anastomosis. The anastomosis should not be under tension, and when you close the replant, you should make sure that there's no bleeding from the replanted part, unnecessary bleeding from the arteries and veins. Try to coagulate the extra bleeders and leave the veins which are anastomosed properly. Okay. The other thing is how to deal with the arterial spasm. When you have a spasm, when you are doing trying to do a replant, stop manipulation, use warm saline, use xylocaine, papaverine, and make sure the blood pressure is fine, and then see whether the tourniquet is on or not. Sometimes the tourniquet may be on, you may be thinking that the artery is not flowing. Okay, so if you wait, the artery will start pulsatile again. And when you are closing the wound, you should make sure that you are not doing a tight closure. Use the minimal amount of sutures to make sure that the vital structures are closed. Use grafts if required to cover the vital structures. If your artery is short, use a vein graft. If your vein is short, use a vein graft. Take care. And if you have a loss of soft tissue and the artery, use a flow through venous flap. And then always do it in the anatomical position of the finger. Don't try to flex the finger and do a arterial anastomosis or a flexor tendon repair. Try to do it in the anatomical position. Okay, and use loose dressings and keep the part elevated. When multiple fingers are involved, then try to do the thumb first, middle finger the second, ring finger the third, index finger fourth, and little finger last. Okay, and so the least damaged digit should be replanted first because it has got the best chance for a successful replant. This again, you can go structure by structure or digit by digit for replantation. So it's a choice, but structured method is preferable because you end up doing it faster and without trying to manipulate all the fingers. If you do a single digit by digit, you may have to, it can lead to manipulation of the fingers. Okay, then there's a zone of replantation, zone 1 and zone 2. Zone 1 is again divided into distal zone 1 and proximal zone. Proximal zone 1, you'll find the veins of the dorsum. In the distal zone 1, you'll not find veins in the dorsum, and you'll have to do it on the volar aspect of the finger. Zone 2 is basically proximal to the FDS insertion. Okay. What are the very distal replantations? Very distal replantations are those replantations in which the replantation is done distal to the distal interphalangeal joint. So these replants, they do well once they are successful, and they are always indicated that you do a distal replantation because your function will be good, the aesthetic outcome of the finger will be good, and the patient is usually happy. There's a distal replant. It's done at the distal phalanx level. So here again, we use the volar veins and the dorsal veins, and we don't use anticoagulants. So there's another case of 2-finger amputation where replantation is done in zone 1. In zone 1, you have better functional outcome. Reason is the FDS is already attached, and FDP attachment doesn't make a big difference in your functional outcome. Okay, there's another finger in zone 1. Okay, okay. There's a avulsion amputation in zone 1. If you see, the distal phalanx is fused, DIP joint is fused, but the patient is able to use the finger usefully. There's again a bi-chain accident. Here again, the DIP is fused. The 2-finger in zone 2. Here, if you see, the flexion of the PIP joint is not good because the PIP joint is fused. And functional outcome per se, it looks okay for the hand, but functionally in the zone 2 amputations, they don't do as well as zone 1. This is again this thing. Okay, this you have already seen. Okay, okay, I'm going back. Okay, so this is again a 2-finger amputation. So replantations basically, and once you have a successful replantation, that means that you have established a good long-term relationship with the patient, and the patient will always be happy that you have saved his finger and prevented him from becoming a handicapped person, and he can do better in life. So he'll be always thankful to you. What are the problems in replantation? The problems in replantation are, first is how to preserve the part. What is the distance to be traveled for replantation? When, how long it will take to reach the replantation center, and where to reach, where is the center where it's being done. So then once the part arrives and the patient arrives, whether the surgeon has to think whether it has arrived in time, it's fit for replantation, should I attend the replantation, how will I manage the complications, and what best outcome I can give it. So here again, and for fingers, it doesn't make a difference. The time is immaterial for fingers. If the patient comes even after 24 hours, you can still go ahead and try a replantation. It doesn't make a difference at all because there are no muscles involved and you don't lose anything by trying for a replantation. What to do with the amputated part? First, don't squeeze the part. Don't wash the part. Wrap the part in a moist gauze. Place it in a sealed plastic bag. Chill it in a mixture of ice and water. And what is it is direct contact should be avoided. Part should not be directly immersed in water. Should not allow the part to dry up. And part should not be put in formalin. We have received parts in formalin, and we have received parts which are frozen also. So this is a ring avulsion amputation. So here usually the outcome is good because it's basically a zone 1 amputation. but the skin level is in zone 2. So you usually get a good functional outcome. There's again zone, means it's a zone 1 amputation, but the skin level of amputation is the zone 2. So you here, again you can get a good function. These are again zone 2, but in thumb, it doesn't make if it is in zone 2, because the thumb, the CMC and the MCP joints, they make up good for the movements. This is again zone 1. Okay. Yeah. Again a zone 1. This material. Okay. Yeah. Sometimes we have a partial, supposing we have very distal replantation, sometimes we end up with having a chemical leaching, sometimes we do, and we end up with a partial successful replant. This again can be managed by adding other soft tissue. Sometimes we get patients who are late. They have undergone a fixation somewhere else, and they come to you with a near total gangrene, means the impending gangrene. So here, the important thing is, here only we have to restore the circulation. We are not supposed to do a vein, because means this dorsal skin is somewhere it is intact. So here means if the turgor is good, then you go ahead with the revascularization. This is okay. This is again crush of the finger. Here a flow through flap has been done. A flow through, a venous flow through, because there is a soft tissue loss here. The flow through flap and the finger can be saved. There's again a cracker blast, loss of circulation in the finger, revascularized, and you can have a relatively useful function in the hand. Okay. This is again a sickle in this